Okay, welcome back from the break. I just want to make sure you got all this, so let me just redo this one again real fast for you, because we're talking a little bit about problematic patients and the patterns of alcohol use that can lead to clinically significant impairments in stress. So just to reiterate, it can be a lack of control over the amount used and or time spent focused on drugs or alcohol. And if you remember what I said was, if you're preoccupied with your use, that's all you think about. Forget your family, forget work. Drugs are number one. Drugs happen all the time. I need it now. I want it now. That's a problem. That's one sign that we have a substance use disorder and preoccupational thoughts. The other thing is the inability to stop on your own. How many times, if you're a drug user or an alcoholic, did you try to stop on your own? And maybe you successfully did. But how long did it last? Was it short-lived? If it was short-lived, that's an issue there. So you can't stop on your own. And sometimes people want to stop. Remember the example I gave you. The poor patient that comes to me and sits there and says, I want to stop, but I can't stop. I just need to use just to feel normal. You'll hear that a lot with opiate users, heroin. Cravings, or a strong desire or urge to use. Cravings are really big, even after you've used and you've stopped and you've been in recovery for year after year after year. All you need is one little trigger, and all of a sudden the feelings start to come back. Or even when you're out of detox and you're out of rehab and you stopped using for a while, you're always going to have that desire. Somewhere along the line, you're going to have a craving. You're going to want to use again and again and again. It affects the ability to fulfill responsibilities in one of many areas of their lives. A lot of times substance users are there and we see lots of divorces, separations, marital annulments, boy and girlfriends being broken up and breaking up, all of that because of what the substances tend to do. They're just overwhelming. They overwhelm. And drug addiction, substance use disorders are cunning, powerful, and baffling. Where do they come? Where do they go? We don't know why. We do know why, neurochemically over the years, but what we do know is it sneaks up on you, no matter how long. You get somebody that's 50 years sober, and all of a sudden they start getting the feeling, oh, I've been in recovery for 50 years, so I must be cured. And then they take one drink, and the next thing you know, they're in the wagon. Well, they know better than that. They know that they're not cured. But the problem is, what's exactly saying to them, oh, you're cured, you can just have one? Well, that's their cravings. The little demons inside, the little cravings inside turn around and sit there and say, this is what I want you to do. You can have just one. It's not going to do anything to you. Unfortunately, that last one can kill them, so it's going to do a lot to them. So, also continued use, despite of having social or interpersonal problems, caused or exacerbated by the effects of drug and alcohol. People will continue to use even if they've lost jobs. Their girlfriend or their wife sits there and says, I want you to hell out of the house, get out of here until you stop using. You don't use, I don't ever want to see you again. Or they lose their children because of that or other things. And you continue to use, you don't think about it. Or you come up with a wonderful excuse and treatment. So you ask your patient, could you tell me why you want to stop it? What's that about? So it's best to use a who, what, when, where, how, and don't ask a why question, I always say. So you ask them, what does it mean to you to stop using? Or what's the purpose of you not using anymore? Well, I'm doing this for my children. I'm doing this because my wife told me that if I don't, then X is going to happen. Or I need to do this because, man, I can't lose my job again. No, those are not legitimate as far as I'm concerned. What's the purpose? The purpose is because I'm an addict. I want to use. That's why I'm using. What am I doing here? Well, I'm here to try to stop using. For me. Not for the wife. Not for the kids. Not for the job. For me. The wife, the kids, and the job are a good motivation to get me here. They're a very good motivation to get me here. But if I'm using those three areas, the wife, the kids, and the job, to turn around and to stop using, I'm going to relapse tomorrow. because it's not about me, it's about them. When it's got to be about me. All right? So important social, occupational, and recreational activities are given up or reduced because of use. So the things you used to like to do, you don't want to do anymore. Because your new hobby now is shooting up. Your new hobby now is snorting. Your new hobby now is, Uncle Jack and Cousin Jim. Your typical liquor store in the tap room. Bar, okay? Some of you may not know what a tap room is. It's a bar. All right. So ongoing use in situations in which it is physically hazardous and despite psychological problems resulting from use. Yes! You're told by your physician. In fact, let me give you a good example of this. I used to work in a hospital in Philadelphia, Mount Sinai Hospital of Happy Memories. It's since closed. And I used to work in the drug and alcohol department in the dual diagnosis clinic. I had a patient come in one time, distended from cirrhosis. And he came in, he said, hey, he goes, I need to get in recovery because my doctor said if I have one more drink, I'm going to die. Boy, do I want to drink. So we went, we had a couple sessions and whatnot. Excuse me. And one day never came back. Nobody saw him. So I did some investigation and I went down, found some people in the hospital that, this was their thing to do. And I said, whatever happened to so-and-so? Oh, didn't you hear? He died. From what? Well, the doctor told me he can't have another drink, and he had one. That fast. And yes, that does happen. One drink can do you in. One drink. So, psychological problems. You're seen by a psychologist, by a psychiatrist, by a social worker, MFT, by a drug and alcohol counselor. They're telling you, you're hearing voices, you're seeing things, you're depressed. If you're depressed, well, what are you doing heroin for? Heroin is a depressant. What are you doing oxycodone for? It's a depressant. Depresses the central nervous system. You're already depressed. So you're depressing a depression. And you put alcohol on top of it to depress it all the more? Or those other things? Yeah, I just can't stop. I got to use it. Right? But this is what this is talking about. You continue to use. That's a substance use disorder. Right? And you're going to have patients like that. You will have patients like that. How are you going to handle them? All right, so tolerance. We need to use more of the drug or alcohol to get the same effect. For those of you who have had me in Phys Pharm, I showed you the tolerance line. And also the efficacy line when you're taking medication. Where you got your baseline down here at 0, and all of a sudden, as you're starting to go up the line, you have that little bit where you're going to have side effects, and you reach your therapeutic dose, and you just level out that, and that's where the physician, if you're taking medication, stops the medications and just levels you out here and says, just take this dosage here. Okay? So you titrate up, you reach your therapeutic dose, and that's where you stay. So tolerance, you need to use more of the drug or the alcohol. So when you first take the drug or the alcohol, you get high, you get that feeling, you like that feeling, and then you start to come down, either you crash or you come down gradually, however it works. And then the cravings start, you want some more, you want to do it again. So you do it again, you use the same amount, and guess what? It doesn't work. So then you take a little bit more. Now you're starting to get that buzz again, you're starting to get that feeling again. Right? So you start to come down again, you start to crash, you reach baseline. You reach baseline, you want some more. So you take that same amount, the second amount, and it doesn't do anything to you. So now you take the third amount, higher, and you keep doing this. So at one point you were down here and this got you high. Eventually about 3 or 4 times you're now over here, just to get the high close to this. This is called tolerance. And the more you use, the more the body is going to get used to it. The more the body gets used to it, the more the body tolerates it, the more you have to use to get the same effect or close to. We also call this in the business chasing the high. Of course, you never reach that high, because to reach that high, you would have to use the same exact dose that you use down here at baseline, not up here. Because from baseline, when you first got your high, you've got all of this space right here, all of it. before you feel anything. Now, if you just use this dose down here, your baseline dose, you're not going to feel anything. It's like, I feel nothing and I need it, and the body's going to be craving it. And the body's not going to stop the craving until it's satiated, which basically means until it's given enough to have that new feeling. Very dangerous. That will kill you. So stop using drug or alcohol continues to avoid experiencing these symptoms. The severity of these symptoms are evaluated on a continuum ranging from mild to severe. How mild are these symptoms? How severe are these symptoms? Okay, mental illness. Symptoms of depression. Let's talk a little bit about mental illness. So now that we have an idea what substance abuse is, we have an idea what it takes to be a substance user, and the idea of tolerance levels. We need more of the same substance or mixture of substances to at least give us to an initial high. All right. We learn that substance use, we become preoccupied with the use. We start to take a look at things, and we no longer need to use any excuses, because every excuse is an excuse to use, right? I have no excuse, so I have to use because I have no excuse. Well, I do have an excuse, and I got to use because I have this excuse, right? So that's the substance abuse, and when you can't stop the behaviors, associated with the use as well, you have the exacerbation. Now we have the second half of it, the mental illness. We talked a little bit about mental illness, but not a lot, so let's go into detail. Let's start with depression, okay? So, what is depression? What does it look like? So, persistent sadness or anxiety or an empty mood. You just feel like there's nothing inside. You feel hopeless, pessimistic. You have feelings of guilt, feelings of worthlessness, feelings of being helpless. You have a loss of interest in things that you used to like to do. You don't have any energy anymore. You just want to sleep all the time, or just, maybe do something, that's about it. You feel fatigued. You have difficulty concentrating. Difficulty making decisions. Difficulty remembering things. Difficulty sleeping. You wake up early in the morning. You oversleep. Right? Your appetite, your weight changes drastically. No appetite, lots of weight gain. Lots of appetite, no weight gain, because the anxiety is eating it away. Well, days, right? Yeah, okay. Thoughts of death or suicide. You make suicidal attempts. You're restless, you're irritable, you're persistent, you have physical symptoms. These are from the National Institute of Mental Health. This is depression. The thing we're watching with depression is suicidal patients and homicidal patients. They're going to kill themselves or kill somebody else. It's a Tarasov decision, and it needs to be sent to a hospital immediately. It needs to be 5150 to call the authorities. The other thing we want to look out for are these two words, hopeless and helpless. For the human person, there are times when you just feel, helpless. I need somebody, I need something. I'm falling apart, right? That's a normal condition, I want to call it, whatever normal means, okay? We all feel helpless. The problem comes in when you start to feel hopeless. When you start to feel hopeless, you bottom out. There's nothing there at all. It's like a black void. It's a black hole. And if the event arises in the black hole, everything gets sucked into it. And there's nothing left. Nothing. Right? You're reaching out. You're trying to climb out of the black hole and trying to get back into the galaxy, and it just isn't working. You're cycling down more and more and more. And what they believe about black holes is the amount of gravity in there is so much that as you enter from the event horizon into the black hole, if you're a human being, it's stretched and stretched and stretched and stretched and stretched and stretched until it just goes pow, and there's nothing left. And it happens very rapidly. Well, the same thing happens when you're feeling completely helpless. Completely hopeless. Where all of a sudden you're feeling yourself stretched and stretched and stretched, and there's no way out. And no matter what you do, no matter how you do it, no matter what your desire is or your dream, there is nothing that can pull you out of it. Very, very dangerous, because the next point of that is suicide. Suicide. So helpless, you can reach out and have somebody give you a hand. And as somebody reaches out and gives you a hand, it's all well and good. Hopeless is that empty hole. So you have all these different things we just talked about. So this is a basic idea of what depression is. Next is anxiety. Anxiety is stress that continues after the stressor is gone. Excessive worry or anxiety about multiple issues, which lasts 6 months or more, and it could indicate either generalized anxiety disorder. Things that just anything can bring on the anxiety. It's a general anxiety disorder. It happens, as it says here, stress that continues after the stress is gone. So you're stressed out about something, you're anxious about something, the anxiety goes away, but yet you still feel that agitation, that rush inside, that adrenaline pump, that just, the heebie-jeebies, the creepy crawlies, all that stuff. It doesn't have to necessarily happen at least 6 months, right? Because you can have something called seasonal affective disorder. Seasonal affective disorder is also part of the anxiety category. And what seasonal affective disorder does is seasonally, you'll start to feel the depression coming in and getting you. Most of the time, people in Northwest, Oregon, Washington State, a lot of them have seasonal affective disorder and depression. Why? Because the sun's not out. It rains most of the time. Areas in the country, Alaska is another one. Areas in the country and areas throughout the world where we see either a lot of days where the sun is gone, or we see darkness, or wintertime is coming and summertime is already gone. There's not enough sun, not enough nutrients, and people start to get depressed. That's called seasonal affective disorder. But as soon as the sun comes out, they start to feel really good again, right? Well, during this time, depression, whether it be depression, seasonal affective disorder, or an anxious depression, whatever it may be, this can be a very dangerous time for the individual. And drug abuse goes up, big time, because they got nothing to do. Right? And if you have nothing to do, you use sometimes, not all the time, sometimes. So general anxiety disorder. Another one is called bipolar disorder. This used to be called bipolar disorder, manic depressive psychosis. It used to be called manic depression or manic depressive psychosis. It may not be easy to recognize at first, since the symptoms may appear to be separate problems, right? So you have intense emotional states during mood episodes, either very manic, very up, or you're crashing very down, or up and down, and up and down, and up and down. This is called rapid cycling, okay? You may be overly joyful or overexcited. These are manic episodes. Or very sad, or feeling hopeless. Remember what I said about that, how dangerous that can be? These are depressive episodes. Sometimes you have a combination of the overjoyfulness and the depressiveness and the sadness. That's called a mixed episode. Mood episodes that continue, both manic and depressive episodes, are called mixed. People can be explosive and irritable during a mood swing, during a mood episode. Extreme changes in energy, sleep, behavior. Symptoms can prevent a person from functioning normally, and when this starts to happen, it's very difficult to deal with these people. It's very difficult to deal with people that are bipolar. They're up, they're down, they're all over the place. Sometimes they won't shut up. They're very anxious. They talk incessantly, or they don't talk at all. They're tearful, or they're doing both. They're constantly thinking. Sometimes they're delusional. Sometimes they can be psychotic. They're grandiose. I had a patient one time that was bipolar, and when he would manic up, when he would get very manicky, he believed that Washington should talk to him, because according to him, he had the equations to take care of the national debt, and he can make it go away in 3 months. God bless him. It would be great if he did. Another time I had a patient that would constantly come in, and she'd be doing real good, and then halfway through the session, she'd just start crying. Just cry and cry and cry and sit there and say, I don't know what happened. I came into the session feeling really good, but now I'm so sad and depressed, I'm just going to kill myself. Hospital time. That's what I wound up doing for a good bit. So these are mood swings. They go up and down. Now, take some of these, and we're going to continue with a couple more of these. But now take these and add a drug to these. Right? You're down and depressed. Right? So you're down and depressed. You're in the midst of a depressive bipolar episode. So you take cocaine, you take methamphetamines, and you start to skyrocket. And as you're starting to skyrocket from the methamphetamines or the cocaine, that triggers an demonic episode. So now you're manic on top of the hyperness from the drug. You're off the wall. You're off the wall. So now you start, the brain chemistry starts to go mixed up. So now with that mania, with the induction of the substance, now you become psychotic. So now you've got a psychotic depressive episode. Right? This is what people do. Talk to your patients about this, will you please? All right. Symptoms of ADHD. We constantly hear about attention deficit disorder. Let me just say, when I talk about ADHD, I want you to be very clear about something. These are people that are truly ADHD. They've been diagnosed in childhood, adolescence, right? Some adults get diagnosed in adulthood. That's called adult attention deficit disorder, adult ADD, okay? Please do not let your patients use ADD as an excuse, right? Oh my God, I can't concentrate because I'm ADD. I use because I'm ADD. I can't go to the bathroom right because I'm ADD. All I know is I can't add because I'm ADD. No, wait a minute, ADD means add. Please, don't do that. ADHD, first of all, attention deficit hyperactivity disorder. And the second thing is, if you're not clinically diagnosed with it, probably don't have it. But at the same time, it's not your job to diagnose. I just want you to be aware of this, okay? Everybody that's out there that sits here and says they have ADHD, they may not. All right? But I also want you to be aware that a good number of the methamphetamine users and amphetamine users may be ADHD. And the way that you find that out is if you ask them, tell me what your behavior is like when you're not using. If they sit there with, I can't focus. I can't concentrate. I'm constantly doing projects and stopping them and starting a new one, right? Or if they sit there and they tell you, I'm trying to feel better, but every time I do an amphetamine, I fall asleep. It has the exact opposite effect on me. That is a true ADHD person. Even if they haven't been diagnosed, send them to a psychiatrist. And make sure you document what they said. Because what an amphetamine should do is what? It should pick you up. If you're ADHD, what they do is they give you an amphetamine so that your frontal cortex and your prefrontal cortex gets a little bit more oxygen in that area by opening up the sulci, in between the gyros or folds in the brain. So the sulci open up, more blood flows into that region. As more blood flows into that region, it's oxygenated, right? And as it's oxygenated, it also starts to feed the brain. As it starts to feed the brain, the executive functioning in the frontal, prefrontal, cortical regions of the brain start to activate, and you start to focus, right? That's the whole idea of giving an amphetamine. For somebody that's for somebody that's ADHD, that doesn't excite them. What it does is it focuses them. For somebody that's not ADHD, it focuses them, but also excites the living daylights out of them. So they're going to get a little bit manic and a little bit hyper, and they're going to be up. The ADHD person, instead of getting up, will focus, but they may fall asleep, occasionally. So just a little something. All right, so one of the most common neurobehavioral disorders of childhood. They have trouble paying attention, difficulty controlling impulsive behavior, trouble staying still, and a tendency to interrupt others. Symptoms of PTSD, post-traumatic stress. Now, once you start thinking of PTSD, as I might have mentioned earlier, not just from war people, but also from people that have experienced some type of trauma. Physical, sexual, psychological, mental trauma, any type of trauma. One of my lectures down the road, a piece will be on vicarious trauma. and trauma that you will see out there. A lot of times, with the research is starting to look at right now, is schizophrenia. Hearing the voices, seeing things, all these positive and negative symptoms that happen. Well, the question is it really schizophrenia that we're looking at? Or could it be that some of these people that we're seeing are dissociating? So when they're hearing voices, what they're actually hearing is a dissociate persona inside them. And as they start to act out, and they start talking to this person that we see delusionally, and they say, well, I'm seeing this person in front of me, are they seeing it? Or is that a type of dissociative identity that they're looking at? Your guess is as good as mine, but it's out there, and the literature is coming out more and more. And so far, what I've seen is it's split. Some people in the field will sit there and say, well, we need to relook at the DSM and the criteria because we don't know what we're talking about. It's not schizophrenia, it's dissociative identity disorder. And on the other half, to sit there and say, you're crazy. There is no such thing as dissociative identity disorder. You're schizophrenic. And if they're worried about you, they're paranoid schizophrenic. And whatever. Labels are labels. They're terrible. So, PTSD, it's an anxiety disorder that some suffer after seeing or experiencing a dangerous or traumatic event. Anyone can get it at any age. Risk factors make a person more likely to suffer PTSD. Risk factors like abuse from childhood, abuse from drugs, all kinds of things. Resilience factors help reduce the risk. 3 categories of symptoms. They experience the symptoms. They have flashbacks. They have nightmares. They have frightening thoughts. The avoidance of symptoms. They have loss of interest, emotional numbness, staying away from triggers or reminders of events. They have guilt. They've got depression. They worry. They're hyper-aroused. It's like that wolf years ago. You see a little dog and someone catches the dog's eye, squirrel, right? One of those things. That's hyperarousal. Hyperarousal, tense, easily startled, angry outbursts, difficulty sleeping, usually constant rather than being triggered. So some of the stuff that we see in PTSD, a little provocation will bring it on. I remember I used to treat veterans at place in the Bay Area, San Francisco, and as I was talking to the guys that were there, it was. I remember there was one time towards Fleet Week. And if you know what Fleet Week is, it's a celebration where the Blue Angels, the jets, fly around and do all their antics, their tricks. And whenever they would hear something like that, whenever they would hear a plane fly by, or whenever they would always sit there and say, I hate this weekend, I can't stand this weekend, I'm just going to shut myself in my room and just hide. Because as they were hearing the planes, it would trigger in their mind the traumas that they used to see in Vietnam. If, or they would hear like a bang from a backfire from a car, they would start, a couple of them would start shaking and some of them would hit the ground. A couple of them hurt themselves, from falling, because it was just automatic. They hear it, they hit the dirt and whack their head on the concrete, and it's pretty messy. So those are some of the things that can trigger from a traumatic event. Other times, moving out of the war situation, what can PTSD be? What do you do with these people who are sexually abused as children? Or sexually abused by, there's a big thing right now with the Catholic clergy. For years, Catholic priests used to be abusing the altar boys and other people in their congregations, and bishops would just move them to another area, the priests and the clergy, and not pay attention to it. So as the years go on, some of these people get into relationships, and then when it comes time, to have intercourse and have sex with one another, they panic, they fear, they get scared, they can't do it, they can't perform. Problems start, relationships over. And other times, tremendous guilt, because they were told, other people, not necessarily ones from the clergy, but other folks, tremendous guilt because maybe they were told, if you tell anybody, relatives happen with relatives, if you tell anybody, I'm going to kill you and I'm going to kill them as well, so you can't tell anybody. Or the father that comes up and has relationships with his daughter and tells his daughter, I'm teaching you what it is to love and to be loved and how to do this the right way. So I'm going to show you how this is done, and it gets pretty disgusting after a while, right? But all this stuff settles in, and defense mechanisms kick in, and the person becomes protective. The internal defense mechanisms, repression and suppression and all these other things start to kick in, and the psyche protects itself. And as it protects itself, it buries this stuff, it represses this stuff, and then somewhere along the line, it starts to come out in somatic symptoms, or physical symptoms, as we know from the Greek soma, body. So they come out in body symptoms of some type. And when this happens, we have issues. All right. So avoidance symptoms. We experience flashbacks, avoidance symptoms, loss of interest, emotional numbness, staying away from triggers or reminders of the event, lots of guilt, depression, worry, hyperarousal, tense, easily startled, angry outbursts, difficulty sleeping, and the like. Other common mental illness lead to substance abuse. You got personality disorders, conduct disorders, schizophrenia, amongst others. Take a look in your DSM-5, Diagnostic and Statistical Manual of Mental Disorders, if you run into any of these issues. Also, don't be afraid to talk to psychiatry. You're going to be in a clinic. You're going to be working in a clinic. Talk to people that know more than you. Talk to them. If you see an anomaly in a patient, tell a psychiatrist, tell a psychologist. Tell a professional that knows more than addictions counseling. What am I looking at? And if you don't understand what they're saying, get them to explain it to you. Don't settle for go read the DSM, that'll tell you, because they use psychological jargon in there. They'll tell you, but it's not. Some of it's plain, some of it's not. But ask them, learn. When you take a look at the charting and you look at it in the medical records, remember I taught you in pharmacology, if you had me for that. Very important course. Look at the medications, know the classifications of the medications, because those classifications are going to tell you, they will tell you what that person is suffering from, right? So if somebody is on Ambien, for example, oh my gosh, they may have a sleeping problem because Ambien is a good sleeper. If they're on Prestige, they may be suffering from major depression because that's an antidepressant. They're on Risperdal. Oh, geez, they must be hearing voices or seeing things or delusional. That's an antipsychotic. So, understand these things, because all this stuff over here, you can tell from the chart. If you don't know, please ask, because all of these personality disorders, conduct disorders, schizophrenia, all the other disorders that you see, people start using. This is where the dual diagnosis comes in. And the cause of the dual diagnosis, well, drug and alcohol temporarily relieve the mental health symptoms for many people. Oftentimes, psychiatric medications have negative side effects that are uncomfortable for the client, and therefore it leads them to stop using the prescription medication and start going to the street drugs, because the street drugs sometimes give them the same amelioration and symptoms that the pharmaceuticals do. The irony is that the drugs and the alcohol have more severe negative side effects than do psychiatric medications. This is an interesting comment, because I've had several patients in the past, and you may have some too, that turn around and sit there and say, I'm not taking any of that stuff that doc gives me, man. That doc's trying to poison me. They don't know what the hell they're doing. They're screwing around with my head. They're giving me these medications. I don't know what's in those medications. Excuse me. But you're going to go to Sidney the Cop Man out there and you have no idea what the hell Sidney the Cop Man is giving you? Because he can be giving you cocaine, in powder form or crack or something like that. That's mixed with strychnine. That's mixed with formaldehyde. That's mixed with roach poison. Are you kidding me? And you know, a doctor's got medications for you that can take these symptoms away. That's been tested and FDA approved. But you're not going to trust that. You're going to trust your drug dealer. You're going to get that. Okay. So the irony is that drugs and alcohol have more severe negative effects than do psychiatric medications, and your patients don't believe it. Even the thought processes of persons who are addicted are not logical or rational. So the drug controls their decisions. And it becomes a terrible cycle where you have to sit there and you're trying to get things straightened out, and unfortunately it just doesn't work that well. Bipolar disorder, right? What drugs are commonly associated with which kind of diagnosis? So bipolar disorder. People with bipolar usually tend to go towards alcohol or cocaine, depending if they're manic or if they're depressed, right? If they're depressed, they'll go with cocaine. If they're manic, they'll go with alcohol, because it takes them down. Cocaine brings them up. PTSD, usually alcohol, right? Benzodiazepines, opiates, sleeping pills to relieve their symptoms because they're usually hyper-aroused. ADHD, attention deficit, usually alcohol and their stimulants, which creates a heightened sense of focus or relaxation to decrease the ADHD symptoms, and sometimes put them to sleep, like we talked about. Okay? OCD, obsessive compulsive disorder. They use alcohol and marijuana to slow down the obsessional thoughts. Remember, what's the classic category? It's a depression. Depression. Alcohol slows down and depresses sensations to mask the mood. Molly and ecstasy create a sense of euphoria. Methamphetamines and cocaine increase the mood, the energy, and the motivation for depressed people goes up. Anxious people will do alcohol, benzodiazepines, and occasionally cocaine to compensate for the anxiety. An anxious person continues to use alcohol and or other drugs. So when you start seeing these drugs, somebody says they're in alcohol, somebody methamphetamines, mollies, ecstasy, benzos, cocaine, learn what these drugs do. Learn what these drugs do. All right? And then start taking the drugs and make a chart for you. OCD, alcohol, MJ, obsessive thoughts. And know why they're doing this. So when they talk to you, you can sit there and get a better idea instead of rooting around and trying to figure out, well, why is this person taking this? Jesus, they're taking it because they have an anxiety disorder. They're taking it because they're depressed, because they're OCD, because they got PTSD. So match the drugs with the diagnosis. That will help you a great deal in helping your patients. And also give you a good idea, a good sense of where to start in your treatment. Because at this stage of the game, you should have your theoretical basis. Which theorist are you following? Your theorist will drive this as well. Because if you did your due diligence and your homework on your theorist, then you'll know how the theorist deals with each and every one of these. So you can take your magic and your theoretical basis, understand what chemical they're using to combat the illness, and then go and treat that. That's what you want. Overlapping genetic predispositions and vulnerabilities can cause a dual diagnosis. So there's a growing knowledge that genetics and predisposed individuals to develop addiction have the same genes that predispose them to other mental illnesses, or that they lead to a greater risk of a second disorder occurring after the first one. So it's estimated that about 40 to 60% of an individual's vulnerability to addiction is attributed to genetics. Environmental factors and stressor genetics also affect the person's decision to make and take risks, which in turn could influence the development of the drug use disorder and other mental illnesses. So 40 to 60% of individuals become vulnerable to addiction because of the environmental factors, the personal factors, whatever it may be, and also genetic predispositions can exacerbate it. Involvement of similar brain regions, developmental strategies, in adolescence, well, it's a vulnerable time. As we know from our physiology that I taught you, and the neurology, the prefrontal frontal cortical regions of the brain are still developing. So you're going to have an adolescence between 13, 11 for girls, so let's say about 11 to 25. Yes, 25 is still adolescence. The brain is still developing. As it's developing, there's going to be a lot of bad decision making, a lot of confusion, a lot of hormonal changes, a lot of restructuring going on. So you start fussing around with drugs in that area, you've got more problems. So these regions of the brain are responsible for executive functioning, such as problem solving and critical thinking. Early occurrences increase rate and risk. There's strong evidence has emerged showing early drug use to be a risk factor for a late substance abuse problem. Additional findings suggest that it may also be a risk factor for the later occurrences of other mental illnesses. So, either the drug that you're taking is going to take a mental illness that's been hidden and bring it out with a vengeance, or what it's going to do is it's going to start a new mental illness. Okay, if you need to stop it here, stop it here, for lunch. If it's still not time for lunch, please continue, okay? This should almost be done. All right, if you've left and you've come back, welcome back. Potential dangers to self and others. Suicide. You have a mental illness, you got a substance abuse problem, that could be a deadly combination. It's a major concern for many clients with co-occurring disorders. 10 times greater risk for suicide for those with the mental disorder than the general population. Right? So this is one of the reasons why I say at every session, and you start this off from the beginning when you do your psychosocial, you greet the person for the first time. You let them know that every session you're going to ask them, are you safe? Do you want to hurt yourself? Do you want to hurt somebody else? And if they keep saying to you, I told you I wasn't going to, just keep telling them, I understand that, but I'm going to ask you just to make sure every session like we talked about. Because there's going to be that one session where you're not going to ask them, and something may happen. So please, and make sure you document in your clinical note, right? In your assessment, right? If you're doing a DAP note, data assessment plan, in your assessment section, maybe the last part I have to close the assessment out. Patient indicates that he or she is not suicidal or homicidal. Patient denies suicide, homicidal ideations, intent, or plan. Put that down, because at that point, if they walk out and kill themselves, you're safe, because you asked a question, you document it, and you're not a mind reader. But this is very important, because it's going to happen. 90% who commit suicide have a mental disorder, or a major affective illness, or PTSD. Alcohol and substance abuse is often associated with suicides. It represents a major risk factor. Clients with co-occurring disorders, especially with affective disorders, have two of the highest risk factors of suicide. Okay? Persons with co-occurring disorders have a strategically greater propensity for violence. 16% of those in jails and prisons are estimated to have severe mental substance disorders. I worked at San Quentin and dealt with this population, and let me tell you, this is so true. Most of the patients I dealt with, were using. Among detainees with mental disorders, 72% have co-occurring substance abuse disorders. Right? Substance misuse and mental illness are risk factors for domestic violence. You know what the worst time of the year is? Super Bowl. Super Bowl Sunday, most domestic violence. Most crime, a good number of female deaths during this time also. Why? Because guys are jackasses. They'll turn around, they'll get drunk, they'll get loaded, and the next thing you know, some of them may have a mental illness that goes off, and that's it, and out comes the violence. These two factors combined to increase the likelihood of domestic violence. Lower inhibitions. Inhibited decision-making skills, lower impulse control are some of the reasons why dual diagnosis clients are more likely to be violent towards others. So treatment, addiction and other mental illnesses were originally treated separately. Why do you think it didn't work? It didn't work because the treatment team has to include professionals and others supported from every part of the client's life. We currently treat all of the client's symptoms and struggles. I've been saying this for years, and for years I've been fought against my colleagues with this. Way back when, before dual diagnosis treatment and addiction treatment was started back when I was really in Philadelphia, right? I came up and I told the folks at the clinic that I was working at, you can't separate them, and they insisted, no, you've got to get rid of this, you got to get them to stop using the drugs and alcohol, and then you can treat the mental illness. And I said, that's wrong. You've got to treat them both together, because as they're coming off the substances, their mental illness is going to go through the roof, and you're going to have either an exacerbation of the symptomology, or you're going to have violence, and that's what was happening. And I said, to cut them both, you need to treat the substance abuse and the mental illness. Yeah, but if they don't have a clear mental illness because it's being masked by the substance use disorder, it ain't going to hurt them. Right? Because as they're coming off the substance, you titrate off the medications and you let the psychiatrist manage it. Problem with it back then, back there with some of the clinics I was at, is you had a bunch of lazy psychiatrists that just didn't want to treat because it was too much of a problem. They had to spend too much time with the patient. So let the drug and alcohol person get rid of the drugs and alcohol and then take it to the psychiatrist. So, and what wound up happening is a lot of drug and alcohol counselors got beat up. Of course, they're coming off their substances and the voices are telling them, go hurt them. So you got to treat them together. Psychiatrists, psychologists, therapists trained to treat both illnesses. Primary care physicians, school counselors, child protective services, other social services, probation officers, judges, Alcoholics Anonymous, Narcotics Anonymous, family members, you treat them both together. It doesn't mean that you're a psychologist. It doesn't mean you're a psychiatrist. But treating them both together may mean you've recognized it, you've noticed it, you've made a good referral. Get them away. Get them referred. And then get a release of information so that you and the other doc can talk to them. Can talk to you, not to them, but to you. Can talk to you and you can talk to the doc. So therefore, you're coordinating treatment. This integrated treatment is called milieu therapy, M-I-L-I-E-U, milieu therapy. We have the entire treatment team working together as one. That's psychologists, social workers, MFTs, drug and alcohol counselors, psychiatrists, nurses. You know, you've got all these folks working together, so when they see something happening with the patient, they can talk to one another, and you can treat the illness together. Integrated treatment includes all the stuff that you've learned to do and will learn from me. Individual therapy, group therapy, support groups, family therapy, medication taking, diet, exercise, life skills, coping skills, education about substance abuse and mental illness, cultural sensitivity and competence, all of this stuff. Because some of these things are embedded in society. Native American culture, for example, they're allowed on the reservations to use peyote, right? What's peyote? Peyote is one of those chemicals that causes delusions, causes hallucinations. Well, in religious circles with the Native Americans, and also in the Native American culture, alcohol is a big one. So you got a lot of alcoholics and you've got a lot of peyote addicts, right? Cultural. All right. So at this point, again, this is just a thumbnail sketch to give you an idea of the complexities of substance abuse treatment. So in this version, we talked about dual diagnosis. You will hear this again when in another class down the road when I talk about co-occurring disorders. You may even see this video again because it's always good to see it a second time, or if not the video, I'll lecture straight to you. But nonetheless, again, understand what you're doing. Make the DSM your friend. Study the patient as a whole. Look at what's going on with the patient. Try to categorize. If the person is bipolar, they may have probably taken these drugs. If they're depressed, they're probably taking these. If they're schizophrenic, they're probably taking these. Make a chart for yourself. Sit down with the patient. Ask the right questions. Talk to the patient. Integrate things with the patient. And as you do this, become a really good therapist that you are. Okay, so that's it for now. We'll pick up on this again tomorrow. And as usual, thank you for listening. At InterCoast College, I'm your doc, Tony Scuderi. Have a nice one. Bye.